can trim the start of the recording, don't worry.
So a warm welcome to all those who are joining. We're just waiting for a few more to arrive. So hope everybody is well this evening. It's certainly a lot chillier than it has been. Okay, we'll give it another couple of minutes. Welcome to those of you who have just joined. We'll be getting going in a couple of minutes. Okay, so it is 6:30. I think in the interest of time, we will get going. So welcome everybody to this evening's webinar. It's going to be focusing on optimizing freehand speech following a total laryngectomy. So our speaker this evening is Alison Dempster. Alison is an SLT by background and is one of our clinical educators here at ATOS. Alison has a wealth of experience in the field of head and neck cancer. My name's Faye Ramasir and I'm another clinical educator, and I'm going to be moderating this evening's webinar. And this evening we have the pleasure of welcoming a guest speaker, which is Mr. Harry Glasson. And Harry is a laryngectomy and has been successfully using freehand speech for a number of years, and he's going to be talking about his experience and answering some questions. So just a couple of formalities before we get started. Please ensure, if you haven't already done so, that your microphones are on mute. This webinar is being recorded and will be available to view on our website. If you have any questions throughout the presentations, obviously please pop them either in the chat function or in the Q&A function, and we will address these at the end of the presentations. And also please be aware that by providing a virtual forum for these questions, ATOS Medical is not providing specific medical advice. The answers provided during the Q&A are not specific guidelines or endorsements. So we're going to kick off this evening with a poll question. So if we can pop the poll up, just something to get us started. So feel free to pop your responses in. Okay, so we're just getting those results in. Just wait for a couple more. Okay. Fantastic. Okay, so first question on the poll was, do you feel confident introducing FreeHands to your patients? So as we can see, 40% of you attending do feel confident and 60% are not as confident. And we asked also about the success rate of how your patients have using FreeHands speech. And again, you can see that about 40% say that 50 to 75% of them have a good success rate. So that's really, really helpful to start off our webinar this evening. So hopefully by the end of it, when Alison has given you her presentation, these may change. That's great, thank you. So I'm going to hand over to Alison now, who's going to take you through the first presentation.
Thanks very much, Faye. So hi and welcome to everybody tonight to our webinar on Provox FreeHands FlexiVoice. Within the webinar this evening, I'll be introducing FreeHands FlexiVoice before providing an overview of the research. I'll then discuss patient considerations and candidacy for the device. We'll then take a closer look at membrane strength and attachment selection, and we'll also consider FlexiVoice tips and troubleshooting. So just moving on to the next slide, please. Ultimately, Provox FreeHands FlexiVoice gives laryngectomy patients the freedom to speak without using their hands to occlude their stoma or depress their heat moisture exchanger. And this has many benefits, which we will discuss. FlexiVoice is attached to an HME with a single click. So in addition to speaking hands-free, patients also gain that all-important pulmonary benefit brought about by the HME, this leading to improved lung health. Just moving on to the next slide, please. Now, I just want to consider some of the features of FlexiVoice. It is a two-way valve, allowing air to enter and exit with a bias open position. The membrane is pressure sensitive, meaning that it's open during breathing, but then closes when a patient begins to talk due to the increased air pressure created by the onset of phonation. Now, it's this forced exhalation that closes the membrane and diverts air through the voice prosthesis and up through the vibrating segment. A quarter turn locks the membrane into open position, and this is created by a plastic arm hooking onto a loop on the back of the membrane. The membrane can be released back into speaking mode by turning FlexiVoice in the opposite direction. So next slide, please. Thank you. There are 4 silicon membrane strengths to choose from depending on the pulmonary support, the strength and the size of the patient. These membrane strengths are light, medium, strong and extra strong. And we can identify the strength of the membrane by noting the number of dots in the front of the device. Light has 1 dot, medium has 2, strong has 3 and extra strong has 4. Okay, and the next slide, thank you. An important feature of FlexiVoice is that its membrane can be locked to hold it in open position during physical activity. And this is important because it prevents the membrane from closing when patients are breathing more heavily and need greater breathability. Speaking is still possible, however, using finger occlusion. On to the next slide, please. So thinking about the benefits of freehand speech, it means that patients are able to use their hands for gesture when speaking, as well as participating in activities such as speaking when driving or writing when using the phone. Speaking hands-free is more socially acceptable, with less attention drawn to the neck area. It's more hygienic than touching the stoma continually. And in fact, a study in 2015 by the anthropological group, the Red Associates and ATOS, revealed that all patients in their study identified hands-free speech as the goal in their rehabilitation. This demonstrating the importance of giving patients the option of speaking hands-free. Next slide, please. In terms of selecting an HME to attach to the FlexiVoice, there are three options. The Provox FreeHands Moist may be used for low-level activities, Provox FreeHands Flow for higher impact activities, or the new Provox Live Hands-Free HME, which is superior to either of the Provox HMEs in both humidification levels and breathability. Moving on to the next slide, please. I'd just like to take a few moments now to look at some of the research on hands-free and FlexiVoice. Just moving on to the next one, please. So the earliest hands-free device was developed by Blom, Singer and Haymaker in 1998, where 50 patients used the product for 10 weeks. Unfortunately, it emerged that the valve on the device closed unintentionally with patient airflow changes, and it was difficult to maintain an airtight seal due to intratracheal back pressure. Just to explain a bit more about intratracheal back pressure. This occurs due to vocal tract resistance, and there are two sources of vocal tract resistance as pulmonary air tries to move through. The resistance created by the voice prosthesis, as well as the pharyngoesophageal segment. A larger diameter voice prosthesis can reduce resistance and therefore reduce back pressure. Unfortunately, if back pressure is at a certain level, the patient's base plate can blow off and prevent optimal voicing. And this was actually why Blom Singer developed their 20 French voice prosthesis to reduce intratracheal back pressure and increase airflow through the voice prosthesis. Moving on to the next slide, please. A study by Landsat in 2015 examined 40 laryngectomy patients over a 6-month period using FreeHands FlexiVoice. It emerged from this study that 37.5% of patients use FlexiVoice on a daily basis, for a mean of 12.6 hours per day. 25% of patients in the study use FlexiVoice on a non-daily basis, for an average of 3.76 hours per day. The reason for this was unpredictable adhesion of the adhesive. So in terms of solving the adhesive fixation problem, Provox Life Stability adhesive has several beneficial features to improve fixation. It's clover shaped for a better fit. It has softer coupling to achieve a better fit directly around the stoma. Stability is stickier than Provox StabiliBase, and patients involved in early trials of stability have reported better freehand speech with stability over StabiliBase. So just moving on to the next slide, please. Thank you. Now, clinical studies have highlighted a link between laryngectomy patients' mental health and communication ability. In 2013, KEST established that overall mental health in laryngectomy patients seems related to successful voice restoration. Brook et al. In 2013 determined that laryngectomy patients without a tracheoesophageal voice prosthesis actually have fewer social contacts than patients who use tracheoesophageal speech. Lydia and Moran highlighted in 2009 that greater social interaction can facilitate recovery after laryngectomy and decrease social isolation. Brook in 2013 established that patients who use a hands-free device have more social contacts. So the literature really does support giving patients the option of using hands-free speech, if possible, for better mental health outcomes. So just moving on to the next slide, please. Thank you. I wanted to also mention a study this year by an SLT, Dawn Kmichik from the Cleveland Clinic in the US. She examined immediate post-op HME use with time taken by patients to move on to hands-free speech. And if we look at the chart, we can see that when patients started using HMEs, 65 days after surgery, it took them 151 days post-op to start using hands-free voice. When patients started using HMEs at day 1 post-op, however, hands-free use was seen as early as 65 days post-op. Patients became independent with HMEs much sooner, and there were improved rehabilitation times resulting in better patient outcomes. We would expect that the earlier patients can use hands-free, the earlier we see the positive impact on mental health, particularly in females, as we know that the mental health of female patients can often be worse than that of male patients following surgery. And on to the next slide, please. So I'm now going to provide an overview of considerations and candidacy for FreeHands FlexiVoice. Okay, when considering the suitability of a patient for hands-free speech, there are several areas we need to consider. Firstly, a patient needs to be able to tolerate an appropriate attachment for an HME, and the patient should be independent with fitting an HME and attachment together. The peristomal area should be stable as lax tissue can bulge, and we also need to consider intratracheal back pressure. So air will take the path of least resistance, and when there's no pressure applied to the stoma created by finger occlusion, the air from the lungs will move forward out of the stoma. This can cause a deterioration in voice quality unless air travels through the voice prosthesis, as well as the blowing off of an adhesive. And as I've said, there are two areas of air resistance as it tries to pass from the stoma to the mouth: the resistance of the voice prosthesis, as well as the resistance of the vibrating segment or pharyngoesophagus. We also need to consider the patient's speaking pressure, because if air pressure is too high, intratracheal back pressure can increase even further. So any attachment used should be able to withstand anterior movement of the stoma. So a tight seal is required to reduce back pressure and direct air through the voice prosthesis and up through the vibrating segment. Any adhesive attachment needs to be more durable than an adhesive used for finger occlusion. If a patient needs to wear a Lary tube, a Provox blue ring tube or a Provox Life white ring tube can be used with an adhesive to create a maximum airtight seal. Okay, moving on to that next slide, please. Thank you. So with the adhesive, we're trying to choose one which best fits the stoma and achieves that airtight seal to prevent air escape. Provox Stability Base is most commonly used by patients who speak hands-free. If Stability Base doesn't fit, the extra base could be tried. The new Provox Life Stability is in fact stickier than Stability Base and may last longer. Moving on to that next slide, please. As I mentioned earlier, blue or white ringed Lary tubes can be combined with adhesives to create a maximum seal, and buttons can be used with clips. So we're now going to consider candidacy for FreeHands FlexiVoice. So when thinking about a patient's suitability for hands-free, they should be able to speak fluently for approximately 15 syllables. If they're unable to do this, then working fluency may be of benefit. A patient should also be able to clean and take care of their voice prosthesis independently. If they're unable to do this, then training and education on VP care may be of help. A patient should also be able to tolerate and wear an HME for at least 20 hours a day and should have been wearing the HME for 30 days minimum prior to trying FreeHands FlexiVoice. If this is not the case, then HME tolerance should be built up. We also need to consider whether the patient's attachment, for example, their base plate, can last for a minimum of 8 hours. If this is not the case, then troubleshooting to find a successful attachment will be necessary. The final consideration is the patient's intratracheal back pressure, which should be between 25 and 40 centimetres of water. If it's in excess of this, consider lowering the back pressure by, for example, using easy onset phonation at reduced pressure. Okay, next slide, please. Now I'm going to provide an overview on attachment and FlexiVoice membrane selection, and we've developed a protocol or guide for this in order to help clinicians work through a process in their selection of the correct membrane. So step 1 in the assessment protocol, selecting an attachment. If choosing an adhesive, the recommendation would be Stability Base or Provox Life Stability. If a patient wears a Lary tube, it can be combined with an adhesive for an airtight seal or a well-fitting button with clips. And on to the next slide, please. So step 2 is how the FlexiVoice and HME fit together. It's recommended that you begin your patient assessment using the medium strength membrane of the FlexiVoice. And this is the membrane with 2 dots. The HME should be placed on a hard surface with the mucus shield facing downwards, as shown on the image on the left of the screen, which shows the Provox FreeHands HME. Place the FlexiVoice on top and firmly push down until you hear a click. Ensure the FlexiVoice is in the unlock position so that the membrane is free to move and close on phonation. The image on the right of the screen is the side of the HME that should be visible on the underside when the FlexiVoice has been attached to the other side of the HME. The HME and attached FlexiVoice can then be inserted into the chosen attachment. And please note that if your patient is using the Provox Life Stability adhesive, there will be an audible click when placing the HME and FlexiVoice into the adhesive due to that secure fit technology informing the patient that it's in place. Just a note about how the FlexiVoice fits with the new Provox Life FreeHands. Just back one slide, please, Hannah. One side of the Provox Life HMEs has the diameter of 22 millimeters, so it fits into the FlexiVoice, which is also 22 millimeters in diameter. The other side of the HME is 23 millimeters, and this fits into the new 23 millimeter Provox Life adhesives, which are also 23 millimeters in diameter. Therefore, we've not changed the dimensions of the FlexiVoice. It fits with both the Provox as well as the Provox Life FreeHands HMEs. Okay, just moving on to the next slide now, please. So moving on to step 3. Once the FlexiVoice, the HME and the attachment are all in place and the patient is seated, simply observe the membrane during quiet breathing. We don't want that membrane to close at this stage during quiet breathing. If the membrane does close during quiet breathing, increase the strength of the membrane to strong and examine the membrane under quiet breathing conditions again. If the membrane continues to close, try extra strong. And if this membrane closes, consider therapeutic breathing techniques to reduce exhalation pressure, bearing in mind that patient suitability for FlexiVoice may need to be considered or revisited at a later date. Once you establish a membrane that doesn't close during quiet breathing, move on to the next step with this membrane strength. So if, for example, the medium membrane doesn't close during quiet breathing, continue to step 4, which is voicing with that medium membrane. So moving on to the next slide, please. So the aim during step 4, voicing, is for the membrane to close at the onset of phonation. You can ask the patient to say along, ah, and observe the membrane. Now it should close on voicing and then open again at rest. If this is observed, continue to the next step with this membrane. If, however, during voicing the membrane blows through the central opening of the FlexiVoice, move to a stronger membrane, then repeat the voicing exercise. Now continue to increase the membrane strength until it no longer blows through when the patient phonates. If the patient continues to blow the membrane through, even with the extra strong membrane, consider trying to reduce the patient's speaking effort and pressure. Once there is a membrane that doesn't blow through, move to the next step. If, however, the membrane does not close during voicing attempts, move to a lighter weight membrane and repeat the voicing exercise. If the patient's unable to find a membrane that closes during phonation, consider working on increasing pulmonary support. And just moving on to the next slide, please. So step 5 involves observing the membrane that was selected in the previous step, but this time during physical exertion. The patient should be asked to walk, but not speak with the membrane being observed. It should remain open during exercise. If the membrane closes on walking in the absence of voicing, increase the strength of the membrane and repeat the physical exercise step until there's no membrane closure in walking. If the membrane continues to close despite increasing the strength, the membrane can be hooked back into open position with the use of finger occlusion to speak. If the membrane does not close on physical exertion, move to step 6, with this strength of membrane. Moving on to the next slide, please. So the final step in selecting the correct membrane strength is observing the membrane during walking and talking. The membrane should close in voicing and stay open in walking when no voicing takes place. If this is what's observed, continue with this membrane strength. If the membrane blows through the centre of the FlexiVoice, change to a stronger membrane, then repeat the voicing and physical exertion step. Continue to increase the membrane strength until the membrane no longer blows through. If the extra strong is blown through, consider trying to reduce the patient's vocal effort. Once there is a membrane that doesn't blow through, continue with this strength. In the case of a membrane that does not close when voicing and walking, move to a lighter membrane and repeat the exercise to determine which membrane closes on voicing but opens on walking. And you should continue with this membrane. If the patient's unable to achieve membrane closure, consider working on improving pulmonary support. And if there's inconsistency between membrane selection during voicing at rest and voicing when walking, consider using 2 separate membrane strengths, one for each situation. Selecting a suitable membrane for the patient can be a bit trial and error, and hopefully these flowcharts provide a structured way of thinking about what you want the membranes to do or not to do in certain situations. So just moving on to the next slide, please. Thank you. Once a membrane strength has been found to work for the patient, you can start to build up the patient's confidence using it by practicing speaking at phrase, sentence and conversational level. Patients may need more than one membrane depending on their activity or situation. They may also be required to lock their membrane, as I said, in open position when they exercise to allow for sufficient breathability. The FlexiVoice should be comfortable, and remember that speaking is possible both hands-free and using finger occlusion without changing the device. Just moving on to the next slide, thank you. I'm now going to talk through some tips and troubleshooting with FlexiVoice to ensure its optimal use and maximise patient success with the device. In terms of coughing, it's recommended that if possible, the patient removes FlexiVoice before coughing, because the pressure created from coughing with the FlexiVoice in situ can reduce the seal of the base plate. If the patient is unable to remove FlexiVoice on time prior to coughing and the membrane pops through the front opening, the membrane can simply be pushed back through into place with a finger. The patient should be able to demonstrate this as part of the assessment process. To manually occlude with FlexiVoice, the device should be turned into locked mode to keep the membrane open. The patient can then occlude the front opening of the FlexiVoice, and in fact, a louder voice may be achieved with manual occlusion. When the membrane's been locked into open position, the patient should hold their breath to ensure that the foot catches the loop on the back side of the membrane, as any air coming up from the lungs can move the membrane forwards. Just moving on to the next slide, please. In terms of taking care of the skin, adhesive remover should be applied to the top of the adhesive to start to break down the glue prior to removal. The patient should then grasp the finger lift tab, applying adhesive remover at the edges of and underneath the adhesive. The adhesive should be carefully, completely removed. The skin should then be gently cleaned and left to dry. Skin barrier should then be applied and left to dry before applying the new adhesive. Moving on to the next slide, please. One of the most commonly reported problems, as I've said, is that patients experience a blowing off of their base plate when using FreeHands, and this is often prematurely, resulting in reduced use of FreeHands. Now, there are some tips for trying to achieve the best base plate adhesion possible. The adhesive can be rubbed between the hands to warm it up, and this will start to activate the glue. Using skin barrier may aid with adhesion, as may silicone glue applied to the adhesive with the skin and left to dry for a few minutes. Thoroughly massaging the adhesive when it's on the skin can aid with adhesion, as can massaging the adhesive if it starts to loosen. Once the adhesive is applied, patients should wait for around 20 minutes before they start to speak, as this will allow the adhesive to bond to the skin without any pressure under it. Alternating between hands-free speech and finger occlusion may also increase the adhesion of that base plate. Now, there's also a device called the FlexiVoice Arch, which can be applied on top of the FlexiVoice, And this is intended to prevent unintentional occlusion of the FlexiVoice opening by the patient's clothing during hands-free speaking. Okay, so moving on to the next slide. Okay, I just want to mention the use of manometry because this can be really, really useful when assessing patients' intratracheal back pressure. It's important that when a patient uses free hands, they speak with a constant, gentle air pressure. As I mentioned earlier, often patients' air pressure is too forceful and therefore back pressure is too high. The result of this being that not enough air flows through the voice prosthesis and the pharyngoesophageal segment. Instead, air at high pressure moves forwards out of the stoma and can blow the base plate off prematurely. Back pressure should be between 25 and 40 centimetres of water when assessed with a manometer. Use of a manometer, in addition to assessing the level of back pressure, can be used as a biofeedback tool for the patient to teach the correct speaking pressures and encourage a lowering of pressure through the easy onset of voice and gentle phonation. The manometer attachment inserts into a base plate and the patient occludes the manometer attachment to phonate. The pressure can then be read. Something to consider is increased pressure as a result of a stricture or hypertonicity, as well as the possible impact of dilatation or Botox on the voice. So just moving on to the next slide, let's have a look at a manometer in action in this clip. There's just a little video clip here.
Okay, so go ahead and take your finger and just say, ah. Okay, I'll go closer.
There we go.
Right.
Yeah,
Yep. And then
perfect.
again. Perfect. Right.
So we can see that this gentleman's pressure reading is 30 centimetres of water. So he's falling within normal limits for speaking pressure. So a useful tool to bear in mind. So just moving on to the next slide, please. It may be the case, as I mentioned, that a larger diameter voice prosthesis will result in reduced speaking effort and therefore reduced intratracheal back pressure. A larger diameter will, of course, reduce air resistance and provide a wider area for air to move through, meaning more air to set that pharyngoesophageal segment into motion. So if a patient is using a 16 or a 17 French prosthesis and has high intratracheal back pressure, it may be well worth trying a 20 or even a 22.5 French prosthesis. It's also important that patients keep their prosthesis clean when using free hands to ensure maximum patency and airflow through the prosthesis. Okay, I just want to inform you of our patient and clinician information sheets we've developed here at ATOS to assist with hands-free speech and that all-important abdominal breathing that we use with patients to optimise their pulmonary support and coordinate breathing and phonation. These can be sent out to anybody who would like them, to let you know about those. So moving on to the next slide, I just want to stress how important it is for patients to be able to coordinate their breathing and speaking for successful hands-free voice. The FlexiVoice membrane is closed by the forced exhalation of air as voicing begins, and so breath support needs to be optimised. Good coordination of breathing and speaking helps to mask the sound of the membrane closing as well. So moving on to the next slide. We also have a device called the stoma support, and this can be used with the FlexiVoice to improve voice quality by providing support to the stoma and adhesive as patients talk. It can reduce the forward movement of the stoma and of air, this redirecting the air through the voice prosthesis. The next slide, please. So there's a choice of 3 different stoma supports. There's flat, medium and deep to suit different stoma depths. The metal head is discrete and the base is transparent. The support's placed over the FlexiVoice and supports the adhesive and prevents or reduces the forward movement of the stoma. The fixation adhesive attaches the stoma support to the patient's chest, and this can make a significant difference to a patient's voice quality. And we've now got a clip of a patient speaking with and without a stoma support on the next slide.
My name is Donato Sena, and today is Friday, and it's July the 8th, 2016. Donato, and I work at Highlands University as a police officer. I'm also the chief of police, and I can really feel the big difference. I can feel the angel bracket, or whatever you want to call it. It really gives that base plate some stability, and it's not popping out as much. And I used to use the other hands, the hands-free, without this other support.
Great, thanks, Hannah. So hopefully you can hear that in the second clip here, the voice is less strained and there's less forward movement of the stoma and less stoma noise. This really enhancing the patient's voice quality. So moving on to the next slide, please. I thought it would just be good to finish this part of the webinar with a sort of summing up of hands-free speaking by one of the SLTs here in the UK. So if we could just play that short video, please. Thank you.
So the desire to go hands-free is really, really important for most laryngectomies, because as somebody once put it, every time you're pressing here to produce voice, you're actually pointing to your disability. You're drawing attention to your abnormality. And what the hands-free does, what the FlexiVoice does, is take that away. People benefit from a hands-free system of communication once they're competent in being able to cover the stoma with their finger and being able to press the HME cassette when they want to talk. When they're competent and proficient in that and feel comfortable and have the motivation to move on to a hands-free, then we go through a set protocol. The first thing that I work on is trying to get the breath support right, because breathing is like petrol for communicating, for producing voice. If we don't get enough petrol in, or air, it's going to be hard to speak. And there's a little bit more pressure that's needed with the hands-free. So getting that breath support right is the key. Then we talk about the hands-free, and there are different strengths, and we try them. And again, I would look at the person's whole body, their whole lung capacity, lung function. If they're big, broad-chested, they might need a stronger hands-free. Another really important factor is getting that base plate right. Because we know there's a bit more pressure that's needed to voice with a hands-free, we want to make sure that there's no leakage, because that's like a leak in the petrol tank. It's going to make it more effortful and harder to produce that voice. So we've got to make sure that the base plate is on properly. So the desire to go hands-free.
Just a slight technical hitch there, but thanks for that, Hannah. And thank you, Alison. That was a really, really helpful, practical webinar which was just packed full of tips and tricks. I'm aware of the time, and obviously if anybody has any questions for Alison with regards to that presentation, feel free to pop it into the Q&A and or the chat. We do have some questions that have come through on email, but what I'd like to do now is pop on the next slide, if that's okay, Hannah. That's great. I'd like to introduce our guest speaker this evening. So Philip Glasson, known as Harry. Harry joined the Merchant Navy in his youth and then went into farming before he started his own tour guiding business called Harry Safari. In 2009, he was diagnosed with cancer of the vocal cords, and he had his surgery in the September, a day after his 58th birthday. And obviously this meant giving up guiding and singing, which is a passion of his. 5 years later, a hands-free device allowed him to sing again, and he's started writing songs and poems. So I'd like to give a warm welcome to Harry. Thanks so much for joining us this evening. Harry, could you tell us a little bit about your journey and how soon after your total laryngectomy did you get to start using hands-free speech?
My journey, like I said, started in 2009, and for about 12 months, I think the first 12 months to 2 years were the hardest to come to terms with, with what was left with, really. But the hands-free, once I managed to get around to that, about 4 years in, I suppose, before I started using the hands-free, 3 to 4 years and one. That changed my life completely, really, because my life is communication, through singing and through the tour guiding. And I've always been a kind of an entertainer, or if not professionally, through friends and stuff. So having a voice was very, very important to me.
Absolutely. Okay, thank you for that. And who helped you establish using FreeHands? How did that come about?
My speech therapist at the time helped me, but they knew how much I was missing, the communication, the singing, and they helped me very, very much in getting the right hands free and everything sorted out, which was wonderful. Because in the beginning, I made one up out of different products from different companies. With a bit of super glue and a Stanley knife, I managed to make something work. It didn't work very well, but it worked, and I could sing a song, maybe two, and then the weight of it became too much. But I mean, the hands free that I use now is just so easy, so wonderful to use, so simple.
Fantastic. I mean, your voice quality is amazing. So that's really good. Can you tell us a little bit about the impact that freehand speech has had on your quality of life?
Well, like I said, I feel almost as normal. I socialize all the time. Nothing kind of phases me. I used to do the odd concert nowadays. I do a few songs and things, but not too often. I don't want to be that sad old fellow on the stage, But being up there, and I mean, I just love doing that. So it's given me my life back. It really has given me my life back.
Fantastic. And I know that when we were talking a couple of days ago in preparation for this, that you'd mentioned there were certain things that people were asking you to do when you didn't have your free hand. So, for example, carry 2 cups of coffee and answer a question.
That was true. Yeah.
Yeah.
And that makes so much difference too. Like you said, picking up something and chatting and going out to dinner with somebody makes so much difference. The driving again, you can drive and talk. It's driving and using your finger to the occlusion is quite dangerous. Changing gear and then talking, and friends have said to me about it. They were all right with you now on driving with like that, but in the beginning it used to frighten us. But so with the hands free, it makes it so just ordinary, natural.
Yeah. Absolutely. So you can do all of the things that you would do previously, but with the hands free.
Yeah, but the only thing I can't do is shout.
Okay. Is that a good thing or a bad thing?
That's probably a good thing. But now and then you'd like to shout, you know what I mean? Yeah. I remember when I first had the operation, a chap I was speaking to, he had the operation about a year before me. And he said, if you hit your finger with a hammer, he said, you will have to put your finger up there and swear. He said, you still do that. And I do. Only with the hands free, it's much easier.
Absolutely. Makes everything easier.
It does indeed, yeah.
So do you have any sort of top tips for being able to use the hands free successfully? Anything that you found that helped?
Yeah, just go for it. Do it.
Just go for it.
don't pussyfoot around. The breathing is the thing, and you can practice that. I've been a singer. The breathing was easier for me, but that's what you need to do. You need to, consider the breathing. I don't even think about it now. I talk as per normal, and now and then things go a bit awry. If I get excited, I've got mine in a button, and I have popped the button out. One time it was when I was on a stage, and it went down between the feet of our local MP. Well, we had a bit of fun retrieving it and wiping it off, but never anybody found my voice, So we had a bit of fun, yeah. But so it does happen.
Yeah, and I think another thing you'd mentioned was the whole mindset around
It is,
freehand.
yeah. I think a lot of it is mindset. I've always been out there, I've been one of those people that's always been out there, but I know that not everybody's like that. And that is the difficult part. And I think really giving them confidence is the first thing, that is the thing. And having hands free, once they've used it, and once they find that they're like, like I am here now, just talking, that confidence will come,
Absolutely. So perseverance is definitely something.
Oh, absolutely. And I know, again, other people who have tried the hands free, I can do it and give up on it. And I think that is so sad, because what does it matter if you sit in your own home just shouting and hollering and, doing what you like, really, and getting used to it,
Yeah.
It don't matter if you're talking to the dog, but, but you just talk.
Absolutely. And did you find getting the balance between breathing and speaking, was that something that was easy to achieve, or did that take practice?
Well, like I said, being I'm a singer and using my voice for a living, I found it very easy. So I'm lucky. I am lucky because I just had the operation. I did not have any radiotherapy or anything like that. So they just took away my vocal cords and that's it. So I am one of the lucky ones in that respect. My voice works very, very well indeed. Yes, it does, and I'm pleased with it.
Fabulous. So we just had a question through on the question and answer. So could you explain a little bit more about the breathing techniques that you use to help achieve really good hands-free speech?
I've got to honest, I do not use any technique. I'm sorry. This is me. What can I say? I don't know. It just came naturally to me. I've never had to work at it. I really haven't.
Okay.
So again, I'm not a teacher, I'm afraid. No, I can't say that any technique, but like I said, confidence is the technique, really. Go for it. And if it blows out now and then, or, go chasing it across the floor and pick it up. The 3-second rule, that applies,
Okay.
Well,
Fantastic.
12 years down the line, so it hasn't done me any harm.
I mean, I think it's just inspirational, really, and the fact that you've got such good voice quality is amazing. And it's
You said earlier on about one of the key factors is keeping it clean, and that is a key factor. Is to make sure that it's kept clean. And you can use the hands free if it's not clean.
No.
Keep it clean and drink plenty. The water, maybe a little chai tea in it.
Fantastic.
It does. When you're talking it or singing a lot, you need to flush the back of it. So a little drop of water every now and then, not a lot, but just a little drop just to keep it clear.
Absolutely. Fantastic. So I know that you've resumed a lot of the activities that you did before in terms of singing, and I know that it would be rude not to ask you to demonstrate that skill. So I wonder whether you would be able to perhaps give us a little
But
song?
as if by magic.
As if by magic, as if we hadn't, asked you to give us a bit of a demo. I think it's just really nice for people to see what can be achieved.
Well, this is a song I wrote when I just after I had the had my throat cut, as I tell people, and it's about life, and I never really thought I'd get this old. I was 70 last month. I never ever thought I'd get this far. So this is a song about that. Rolling back the years, all those days of fun. Never thought I'd get this old with all the things I've done. I never gave a thought to live into old age. Yes, I read the book of life, but I never did turn this page. Life is what you make it, son. Live it while you can. You can't do all the things you want when you get to be an old man. So if you don't hurt nobody, no one's hurting you. Live every day like it's your last, is what I advise you do. Yeah, live every day as if your last, is what I advise you do.
Amazing.
There are a couple more verses, but I won't bore you to death with me singing.
No, that's amazing. I think the nice thing that comes across, certainly from a speech therapy point of view, is the intonation that you're able to get and the change in pitch with the voicing. So I think it's just really, I mean, the song itself is inspirational, but I think the fact that you were able to do that now is just amazing.
I love it.
Yeah, well, I mean, thank you so much for sharing your story with us, and also for giving us the demonstration. There's a couple of questions that have come through for Alison, actually ahead of time. Just a little bit going back to the FreeHands presentation. Obviously, if anybody has any questions that they would like to ask Harry, there's still time for you to pop things in the Q&A or the chat. But Alison, a question asking, what's the device lifespan of the FlexiVoice?
Device life is approximately 6 months if the device is still in good working order. After 6 months, they can develop slight air leaks. The membrane might not close as efficiently as it did in the beginning. So I would be just keeping an eye on it, sort of approaching the 6-month mark with a view to replacing it, at that level.
Fantastic. And there was a question actually about how you go about cleaning the FreeHands FlexiVoice.
Yeah, and I know you mentioned this, Harry. I don't know if this is in keeping with what you do, but certainly we recommend as a company cleaning and disinfecting the FlexiVoice daily. So it can be submerged in washing up liquid and water, making sure that the membrane's in the unhooked position. We don't want it hooked back. We want it to be able to be flexible when it's being washed. And then disinfecting it in 70% ethanol is a good solution to use, making sure that it dries thoroughly before it's reused. So that will prevent any sort of contamination or buildup of microorganisms. Is that similar to what you do,
I do more or less that, except I don't disinfect it. I just clean it with, as you say, just washing up liquid, and I put it in water and leave it soak for, I don't know, maybe half an hour or so, and take it out, give it a good wash off, and then put it up and leave it dry. Like you said, that's the thing, is leaving it dry thoroughly.
Yeah. How long do you let it dry for? What would be the time for that?
Oh, probably overnight or something like that, probably.
Okay.
Fabulous. That's great.
I just had a question for Harry as well. I know that you are using a Larry button with the FlexiVoice and HME attached to that. Have you always used a Larry button, or was there a time when you used a base plate or a tube?
In the beginning, I was using a base plate for the first hands-free I had, and I couldn't get through a verse of a song, or if I got through very quietly, I might be able to get through without, pushing the plate off. I tried all sorts of glue and that, but I got sensitive skin, and they've really made a mess of my neck in a way. And I knew I had to go down a different line than the back plate. So that's why I used the button. And the button, I just used the button. I can show you. That's it. I just used the button as it is.
Yeah. Yep. And that's obviously forming an amazing seal with your stoma, because I can't hear any air leak when you speak at all. So and that's key really, isn't it, is to get that really good tight seal so that no air can come out.
It seems to do that very well. I can't complain at all. No, I don't have I've never had a problem with air leak.
Yeah.
Like I said, occasionally I'll pop it out if I give too much, make too much effort, or yeah.
Because I think that's key, isn't it? And that's what I said in the presentation, that breathing is key. Both, making sure that you have got enough air support there, but also making sure that it's very gentle breathing during voicing, because any forced voice or too big a breath in and too much force is going to that air is going to move forwards. So do you find that you had to sort of relearn just to keep the airflow at a really gentle level throughout?
I think probably I just kind of naturally got into it. I don't do it consciously.
Okay.
But yes, I do. And I'm used. This is the medium, by the way, that I use. Okay. I've tried the stronger one, and the stronger one's good if you're out perhaps walking or something. But you've really got to give it a bit more punch. To actually voice. Otherwise, you're making all sorts of rude noises.
Okay. Okay. And how do you get on with the medium membrane if you're out walking and talking? How does that?
I'm not so keen on it, to be honest with you, because if you're wearing a button, I suppose as well, I find that impedes walking a bit. So I use a back plate normally when I'm walking.
Okay. Okay, great.
I can do it. I turn it off, and like you said.
Yeah, so you just turn it to hook the loop so that it stays open. Yeah.
That's what it's doing now.
Yeah. And how do you find your voice when you occlude with your finger? So when the membrane's in locked open position and you occlude with your finger, do you find that you've got a louder voice?
I don't think it matters very much, really.
Okay.
Maybe I could, I can make a lot more effort if I wanted to,
Mm-hmm.
So I could make it louder, I suppose.
Yeah.
When I'm singing, I just turn the amp up.
Yeah.
I'm loving the problem solving. Very
Excellent.
good.
Yeah. Thanks, Harry. That's really helpful.
Fantastic. Just one more question for you, Alison, is can the FreeHands FlexiVoice be used at night?
No, it's recommended that patients don't use it at night in case the opening becomes covered with duvets and bedclothes. It is recommended that somebody just wears a regular HME overnight, or the FreeHands HME with the titanium cap on the top. Yeah, just to keep everything patent and risk to breathing and the breathing stopping overnight. Yeah.
Wonderful. Great. So I think that was the last question, I think. Yeah.
What do you use, Harry, overnight? Do you use a regular HME?
Shouldn't have asked me that, really, because I don't use anything overnight. I take a, but I don't, when I go to bed, I don't put anything on.
Right.
Originally I used to put one of those, like a bib thing around. And I've used like a foam, a little foam thing.
Yeah.
And I find now I haven't done for several years. I don't wear anything at all.
Okay.
I don't find a problem.
Okay.
And how is your sort of mucus? Do you find that you have a lot of mucus? Or...
No, not really. I don't. I'm very lucky. Like I said, I am one of the lucky ones. I really am. Everybody out there is going to say, "Oh, you're boyfriend," but it's true. I can't complain. No, I don't. A mucus problem, really, like that.
Good, good.
I'm very lucky. I'm happy, very happy.
Good. Well, that we can tell, and the singing definitely proves that. I'm aware that we've got just a couple more minutes, so I just wanted to say a massive thank you to Harry for joining us this evening, and again for giving us that amazing rendition of your song. Thank you to Alison for a really informative and really practical webinar session. For those people who wish to have copies of the flowcharts that Alison presented, then please get in touch and we can obviously share those with you. And obviously our clinical education team are happy to help support with any patient queries that you might have within clinics, or if you've got any freehands groups that are running. And again, obviously, if you have any clinical queries at all, then you can email us on the clinical support at atosmedical.com email address. But again, I just want to say a great big thank you to our panelists, a really informative session, and it was an absolute joy to hear Harry sing. So thanks for everybody for attending.
You can find me on YouTube, by the way, if we're singing with this.
Fabulous. So yeah,
great.
Yeah, if people want to share that with other people who are aiming to achieve hands-free,
Exactly.
what an inspiration.
It could be, look on YouTube, it's on there.
Yeah.
Fabulous.
Okay.
So that's brilliant. Well, we're 3 minutes ahead of time, so hopefully everybody can enjoy their evening. And like I say, thank you for attending, and thanks to our panelists. Have a great evening.
Thank you. Thanks.
Thank you.
Good night, everyone.
Good night.
Bye. There will be a short survey for those who have attended, so it'd be great if you could just fill that in before you leave. That'd be great. Thank you.